ankle, and we pull up a specimen there. As we get down to the foot, when you look at the structural differences, like between, I'm going to talk through a couple of slides here just showing you, is when you talk about the hand versus the foot. We don't walk around on our hands generally, and so the foot's different in that it's set up to maintain that load bearing, be able to have push off, spring off of that foot when you walk. And if you look at the tibia and the fibula, it creates what's called the talar mortise joint, which is just how the talus that we see here rocks back and forth between the lateral malleolus and the medial malleolus, or the distal ends of the tibia and fibula. So the only bone of the foot that actually articulates with the leg bones is the talus. That's called the talocrural joint. We're going to talk about structural stability, how that works, how it's strengthened. It has a capsule around that joint, but it's really, really, really thin. And so you have very strong medial ligaments, and then pretty strong lateral ligaments, and a lot of other ligaments in between. We're not going to spend a lot of time up in the high ankle talking about like high ankle sprains, but that's how it's set up. So we talked about motions of the foot, and I said we're going to take out, that's one of the things I got to go back and there was a reference to supination, pronation. And those do occur in the foot, but they're a combination of actions. So we're not going to worry about that. We have eversion, inversion, dorsiflexion, and plantar flexion. So this kind of repeats what I was saying in the overview. The tibia, talus, fibula, talus, that's all part of your ankle joint. And so the tibia is going to transfer the weight to the foot. But your fibula is just going to stabilize. If you're out rucksacking and you can't do anything different to walking back, you break your fibula, right? You splint it up, you'll probably make it. You break your tibia, you're not going to be able to bear weight. Not without a lot of assistance, right? So the fibula is the stabilizing bone. The tibia is going to be our stability, how much weight we can put on it. And then I put a note in here, the talus is wider anteriorly, posteriorly than it is posteriorly. You'll see that more in the lab, it's kind of harder to see in this. But when you're standing on your toes, the anterior opening here is much wider than it is posteriorly. So when you're up on your toes, you can do this with the cadaver tomorrow, and you can see that you can kind of rock that talus back and forth. This one's pretty stiff. But when you dorsiflex, it locks in that joint, and then you can't invert and evert as well. So you're most stable in dorsiflexion. That's why like dancers, they come up on their toes or high heels, and your ankle's very unstable at that point because of basically how the talus and those bones meet. Okay, fibrous capsule. I already said it's thin, but we're going to use ligaments. The medial side of the ankle is the deltoid ligament. Medial ligament, deltoid ligament, which is actually a collection of 4 ligaments. I'm not going to ask you to learn the individual 4 ligaments because most of the time you're not going to see a medial sprain. You're going to see lateral sprains. But there are 4 different ligaments that I'll show you, but you don't need to know them. And so the job of the medial ligament, deltoid, is to stabilize the medial side of the ankle and keep you from everting. Which we already can't evert very much because we have a bony block also. Then the lateral ligaments we will learn, the 3 ligaments there. You have 2 collateral ligaments, and a collateral ligament. You have collateral ligaments, and they're a little weaker than the medial side, but there are 3 of them, and we'll talk about how you like grade ankle sprains and things some of y'all are used to. So I just boxed medial ligaments. So these are the 4 ligaments. You don't need to, I'm not boxing these for a reason. You don't need to know. There are 4 ligaments here that help make up this medial ligament. It just helps you keep from everting. And this is where we get into our big box, which you do need to know is the lateral ligaments. If you've ever heard of like a grade 1, grade 2, grade 3 ankle sprains, that's a general reference to did you tear or damage the ATF, anterior talofibular, calcaneofibular or the posterior calcaneofibular, kind of in that order. So if we look closely here, there is a ligament that comes from the fibula to the tibia, really to the talus area there. But that's the anterior talofibular ligament, your ATL. So most of you in this room have probably at some point in your life sprained your ATL. So that's pretty common. If you have a mild ankle sprain, you sprain it. Some of you have torn that ligament and may not even be intact anymore, but your ankle's still stable. And it's not going to make your ankle unstable. You're just more subject to chronic ankle sprains. Then you have a ligament that comes off of the fibula and goes to the calcaneus called the calcaneofibular ligament. And if you want to number these, we can say, well, that's one, like if you're used to grade ankle sprains. That's two. So two is the calcaneofibular ligament. And it's just helping to stabilize that side. If you tear both of those ligaments, that's somebody who's probably going to be in a walking boot for a while because your ankle is pretty unstable at that point. Of course, if you tear all three of them, that's going to make you very unstable. Now, the posterior talofibular ligament, back here, you just can't see it well because it's here, off of the fibula, going back to the talus. Fibula, talofibular ligament. So that would be three. And you'll see all three of these in the lab. Now, I boxed one ligament up here just to tell you. Some people always ask, well, what about high ankle sprains? Well, there are other ligaments, but don't confuse them because you look at where they go from. We're talking about ligaments that go from the fibula to bones of the foot. So the lateral three ligaments, anterior tibiofibular, posterior, anterior talofibular, talus fibula, posterior talofibular, talus fibula. They're going from the fibula to the foot bones. High ankle sprains, you start looking in between those two leg bones. So it's named that anterior inferior tibiofibular ligament. These are going between the actual bones of the leg. So they're not really what we see all the time in ankle sprains. So if you're going to injure your ankle, it's generally going to be the anterior talofibular ligament. You generally will not sprain the deltoid ligament, and if you do, you're going to have a lot bigger problems. Because if you look at an ankle, the medial malleolus, we said this ligament's deltoid ligament, medial ligament's very strong. Not only that, if you try to invert and evert your foot right now, you can invert your foot to a much larger degree than you can evert it. The reason for that, if you look at the fibula here, it goes down lower than the tibia. And when you try to evert, you got a bony block. You're hitting the distal part of the lateral malleolus of that fibula. And so most of the time, if you're able to sprain the deltoid ligament, like you see these on like fast ropes, people come down and you're able to force your foot into eversion, you'll fracture the fibula. You don't generally see people come limping in on just a medial deltoid sprain, like you do with the lateral side, if that makes sense. Alright, so if we look at just the foot and all of its bones and articulations, we look at how it's set up to bear weight. There are a lot of different ligaments that connect these. We're not going to go through every single one of them. But we are going to start to look at foot conditions. Okay, so you need to separate. It's still warm in here. Y'all still warm? You need to separate when you talk about forefoot, midfoot, hindfoot. And those of you who are clinical before, it's a little harder because you think about things differently. You know the condition or whatever already. You don't always think of it this way. But textbook medicine type stuff, there are different injuries that are considered forefoot versus a midfoot injury versus hindfoot. And so I want you to kind of pay attention to those because as you go through like ortho and stuff, that's going to help you with any questions and things. So I start to show you that here. So the forefoot's considered toes and metatarsus. The midfoot's where you find those other bones, right? Cuneiforms, cuboid, navicular. And then our hind foot is our calcaneus and our talus. So here are the common conditions. And I'll point out why I said that openly to it. So the forefoot's where you're going to get most of the complaints. And most of that, actually all these foot conditions we're going to talk about, a lot of them are going to be because of poor footwear. Right? Yeah, you can have degenerative changes as you get older, but a lot of times it has big cause is your footwear selection. So these would include things like bunions. We'll discuss them more later. Stress fractures, or we're looking at metatarsal fractures, specifically the base of the fifth metatarsal. Anybody ever rolled their ankle and tore their ATF and they might get a grade 2 ankle sprain? Sometimes you can avulse one of the tendons and fracture the fifth metatarsal base. Anybody ever done that? Bad ankle sprain? What keeps you, if you, let's say all three of your ankle, lateral ligaments of your ankle have torn. What at that point keeps you from inverting? You know, linking back to what we've already learned. Fibularis longus, I know it was all on the top of y'all's heads. Fibularis longus and brevis. Remember, fibularis longus, those are the two lateral compartment muscles, both innervated by that superficial nerve. Anyway, it's going to keep you from inverting. Remember, those are strong everters. Fibularis brevis inserts at the base of the fifth. So if you roll your ankle in, you can tear that off. Fibularis longus went all the way under the foot and attached to the first metatarsal plantar surface. So anyway, I brought that back up just to kind of link it. And that's the same thing. Have you ever seen people, like I used to do a lot of this when I was at Fort Benning doing physical therapy. Students that are coming through, some of the ranger students who come in there for a while and rehab their ankle. And we do a lot of proprioception training, like standing on one foot. And you ever seen that trampoline where you're throwing the heavy ball against it, like the sandballs? Or you can stand there and use a tennis ball. And what that's teaching you is proprioception, knowing when your ankle's about to roll in. And so if you're standing on one foot and you're being moved around, your ankle's already unstable. So now we're teaching the fibularis longus and brevis that as soon as your ankle starts to roll in, to tighten up. And that'll help you keep from spraining your ankle. And that's what they're doing with that, teaching proprioception for that condition. Okay, I'm a little too far off. Getting into interesting stuff, we gotta stay with my boring stuff. Midfoot fractures, midfoot sprain. Midfoot sprains are miserable. I don't know if you've ever had one. They take forever to it's not like you can't walk or you gotta walk around. You're not fractured, you don't need a cast, but they just take a long time to get better. Posterior tibialis is fine. We're not gonna get into that, but it's associated with tarsal tunnel syndrome. And then the hind foot. So overuse, excessive weight. This is where we find things like Achilles tendonitis, bursitis, and then the infamous plantar fasciitis. So I brought up earlier when I said that some of y'all were clinical before, where do a lot of people complain of plantar fasciitis pain at? In the arch, right? But most of it, if you know that you have plantar fasciitis and you get up in the morning, you'll notice that your heel hurts a lot. Because the plantar fascia, before it hooks to that aponeurosis under the foot, got my hand on the foot, it attaches to the calcaneus. So the plantar fascia is here. And when it starts to pull and gets tight along this area, yes, you're feeling pain at the calcaneus in your midfoot area, but it starts back here and it's pulling. And if it continues to pull and you don't treat your plantar fasciitis, it'll start to pull away that connection. When it does, it'll start to calcify, and that's when you get that heel spur. It'll develop a burst over. It gets very painful. So most people, though, think of plantar fasciitis that are clinical and go, oh yeah, they always complain that their arch hurts. But this is textbook medicine. So if I or somebody else asked you, you would say plantar fasciitis is a hindfoot problem. Just, that's the difference. If I don't say that, if I was to ask you that, people that are clinical would be, well, wait, they complain here. I know, but what slices, you know what I mean? That kind of thing. Most people, I'll get a little off topic for a second, is most people with plantar fasciitis, it goes on and on and on and on. Why? Because they don't realize to do certain key things. Now, I've had it several times before, but when you have plantar fasciitis, your plantar fascia gets very tight. And what the problem is you're getting little micro tears in that fascia. And when you really get them is after you sit here for a long time and get up, right? You start hobbling for a little bit and then you walk and it's fine. Because you're stretching that plantar fascia. So think about when you get up in the morning. And if you have plantar fasciitis, how many times do you stretch it before you get up? You've been sleeping all night. And it doesn't matter if you're sleeping with covers over your feet. What does it put in your, using my hands. When you sleep, you have the covers on your feet, it's pushing your toes down, right? What does that do to the plantar fascia? Puts it on a relaxation, right? Probably feels good. Because it's bending your toes down, that fascia is being shortened a little. And then people say, well, I sleep on my stomach. All right, well, same thing, right? Your feet are like this, unless your feet are hanging off the bed. I'm sure there's somebody there, all right, we're hanging my feet off the bed. Okay. You're still shortening it. And then there's always the other outlier that goes, yeah, but I sleep on my side. Whatever. So when you get up in the morning, or in the middle of the night, most people do what when they first wake up at night? Go to the bathroom, right? I mean, it's pretty common. So they get up, and what do? They have plantar fasciitis. They get up and hobble over there, right? Trying to get it, I just got to work it out. Every time you do that, you're causing more little micro tears, and you're just setting yourself back. So you should keep a towel by the bed. They make balls, like tennis ball looking things. I don't know. You can pay $40 for a ball that you can roll your foot over, or you can get a tennis ball. Or a can of beans. You know. But stretching your plantar fascia is the easiest. If you're tired, especially when you wake up, get you a towel or even use your sheet that's there, and you put it over your foot like you're doing a hamstring stretch. And just stretch your plantar fascia before you get up. I'm telling you all that because patients are going to come in complaining of plantar fascia forever. It's never going to get better. And people will start giving them like, well, I'll give you an arch support. Okay, you're just causing other problems. Why not teach them how to do it correctly? Last thing I'll say is any condition that's like this that you get people stretching for, I know I already told you this, what do you do on their first follow-up when they tell you they're not getting better?
Perform it in front.
Yeah. Show me the exercise that you're doing. They won't be able to show you. Like, I'll do some funny things. I'm doing this. Okay. Observable features of the foot. Now, if I was writing a medical textbook, and I say this every time, I'm never going to change these pictures unless we completely change all the books. Why did they choose this person? I mean, this belongs in a derm book, not a normal anatomy textbook. These are some ugly feet. But, some people just have ugly feet. It's like genetic. I don't know. I mean, I could do modeling on my feet. You know why my feet are better than yours? And I don't know if I told this class. I told the last class, and they were appalled. Because there's not a time in the day from the time I wake up to the time I go to sleep that I do not have shoes on. And they were appalled that I wear my shoes in my house. And y'all probably are too. I don't get that. My kids don't. They run around without shoes. See, I'm not even going to get there because I know you don't agree with me. How do you walk around all day without shoes? Everybody has their own opinion. They were more worried about the germs. What's that? Here we go. Extensor digitorum. Yeah, extensor hallucis longus. You can see those nice tendons pop up. We're just breezing through these. You have your lateral and medial malleolus. The medial malleolus being the distal part of the tibia, and the lateral malleolus being the distal part of the fibula once again. There's extensor digitorum longus and extensor hallucis longus. The only reason I put this picture in here is because I told you we're not going to talk about the retinacula like we did in the ribs. But there are two different retinacula that help to hold down these tendons. Probably never hear of them again, but they are there. So you have a superior and inferior extensor retinaculum. There's not a true flexor retinaculum, but really the flexor part comes from the tarsal tunnel, which we're going to look at the components of that. And then I threw this in here. I didn't box line this, just for reference. There's some good things that you can point out here. Is this is fibularis longus and brevis. So you can see brevis going to the base of the fifth hair, and then longus going completely under and making its insertion over here on the medial side, plantar surface. And then you have extensor digitorum. This is another reference where you have 1, 2, 3, 4, and 5. So what's this one? This is not part of extensor digitorum. That is fibularis tertius. And that's a reminder to take you back to learning your compartments, because I told you the two lateral compartment muscles are fibularis brevis and longus. But fibularis tertius, which sounds like it should be in that compartment, is not. It's an anterior compartment muscle. And then a view of the tarsal tunnel. No, I don't need you to spend a lot of time on these last three pictures. This is the tarsal tunnel. So this is your calcaneus. And just anterior to that, you have this area, and you can actually feel that on yourself. With their skeleton, where you have all your extensors coming up here. Your flexors don't like put the wrap over your calcaneus. They go down through this area called the tarsal tunnel. And so all I need you to know for me is what are the components? What's actually in the tarsal tunnel? In order. So I gave you a black and white photo, but I think that's the easiest way to look at it, and it's numbered. If you go, the first one here, number 8, that is going to be tibialis posterior. And there's a way you can remember this. This has been around forever. Tom, Dick, and Nervous Harry. That's the components of the tarsal tunnel in order from anterior to posterior. So tibialis posterior, and then 9 would be, that would be your Tom. And then flexor digitorum longus would be the big portion of it. And then and would be the artery, in this case the posterior tibial artery. And then behind that, you look at number 11, you would have the tibial nerve, or nervus. And then number 12, back here, I'm sorry, I'm drawing black on black. Then you have flexor hallucis longus. Now it makes a note on here, 13, 14. We got those. They're gastroc tendon, calcaneal tendon. That's how you remember them. Tom, Dick, and Nervous Harry in their order. If you're going to confuse anything in that, you will confuse tibialis posterior versus tibialis anterior. And the last part as we start to finish this out is looking at foot conditions. So I've opted, instead of learning all these little bitty muscles of the foot that you never really hear about again, I said, well, let's switch. I'll introduce you to a bunch of foot problems that'll help you more later than learning the sole of the foot. It's very important to know the hand muscles. You're going to see that again, like the tarsal or carpal tunnel and stuff. But I don't know if I've ever talked to anybody about the sole of the foot muscles again, except in here. So I just took it out. So hallux valgus. Hallux valgus is meaning L, remember L, valgus, is a lateral deviation in the great toe, where it should be straight, but because of footwear, degenerative conditions, aging, that toe starts to turn in. Okay. Eventually it's going to get stuck like that. Right? Your first toe, or your great toe, is going to be under the second toe, and it's going to get stuck in that position because there's sesamoids under the great toe that get locked between the first and second digit, and so it winds up staying like that. And then you'll start to develop what's going to be on the next slide. You'll start to develop your bunion. And you'll be complaining, my bunion's killing me. I was about to quote Fred Sanford, but I know nobody knows who Fred Sanford is. One person does. He's over there. Ethel, I'm coming to join you. Anyway. Have you ever looked at, well, y'all have to wait a little older. Sometimes you ever seen they have pictures now, they'll say, like, they'll put up these actors that when you were like in your 20s, I know some of you are like, yeah, I'll have to wait a while. When you were like in your 20s, and they put up actors from when like, I was in my 20s and would watch certain TV shows like Fred Sanford, they'd be like, how old is he? And he'd be like 45. And I'm like, my goodness, people look much older back then. I do miss 80s hairstyles though. I don't know why I just thought about that. I mean, your hair could catch on fire at any time. Not my hair. Alright, valgus. This is pretty common, you'll see it. One of the cool things about this I found out in phase 2 is I'd never seen them. What do they do with hallux valgus if it's like that and somebody needs to repair it? Yeah, you can treat that bunion and pack it up and all, but how do you actually fix that? And when I was doing podiatry rotation, I thought it was the greatest thing in the world. It's fun. I don't do toenails, but I don't mind drilling into your foot. They'll take that, like at the metatarsal phalangeal joint, they'll take that and break it and straighten it out. And they'll take a rod, just like I was drilling in my golf cart this weekend, drill underneath that toenail, just straight into that foot, put that rod in there and kind of cut it off. And then you walk around like that until it fuses. And then when you come back, you're out for that. When they come back, the part I like is when they come back, you take a pair of wrench, pliers, whatever, and just yank that out of there. They don't even feel it. It's kind of cool. I thought it was, see, it goes all the way back when you said the whatever injury. Cool. That's pretty cool. I like that. So, once again, I don't have a problem cutting your toenail off, but I'm not drilling your toenail. The day they tell me in my job I need to do that, I'm just going to quit. Not walk upstairs. Yeah, that's right. Well, that's my turning point. The bottom of the first 4 stairs. If I take the first step up, you know that I'm going to come on up. I'm just going to go back home. Bunion. Bunions are killing you. That's your metatarsal phalangeal joint. Most of the time, this is associated with hallux valgus, but it doesn't have to be. A bunion is actually, we think of a bursa. There's not normally a bursa there, though. Bursas are normally found between like tendon and bone, or between 2 tendons. And so this bone actually can become deformed also. But you start to develop this bursa and soft tissue out there swelling, and that gets inflamed, you get that like a sac or a bump there, that's the bursa. And it can become very painful. And then we talk about flat foot, pes planus. So if your longitudinal arch collapses, or you were born that way and you have flat feet, your arch is coming in contact with the ground. I put up there's a wet footprint test that you can do on people. You know, if you jump out of the pool and your footprint's on the ground, you should be able to see a nice kind of arch there in your foot. If you have this kind of look to it, where there's just slightly arch, you have flat feet. In general. We know flat foot's not as bad as they once thought. I say that because they used to say people with flat feet shouldn't be road marching. Plenty of flat-footed people that don't out road march all day long, right? Once again, it's another condition where what if you saw, well, I'm talking so clinically, what if you saw, 23-year-old soldier, high speed, and he comes in and you just happen to notice during an exam he has flat feet. He's not complaining of that. There's nothing to do about that. You go and give somebody with flat feet, pat them all their life, you give them arches, arch sports, you're just hurting them. Right? They're used to that. Wait until they start complaining. Alright, flat foot. Flat foot in a baby is normal. So we look at the pictures of little baby feet when they stamp them when they're born, and they put them on there. They look completely flat because babies have a fat pad there. That fat pad will eventually go away and the arch will develop, and the only fat pad that stays is down over the calcaneus. If you didn't know, you have a nice big fat pad at the bottom of your calcaneus that keeps you from walking on bone. So flat foot may or may not cause problems with babies, that's normal. And then two of my favorite. We got a couple of specimens of these two over there. Claw foot. I don't want anybody ever put in my chart claw foot. Flex or hammer toe. Hammer toe, I can live with that, not claw foot. You'll see, if you're working in a nursing home, you'll see a lot of these. But what we need to know for ortho, there's a difference between claw foot and hammer toe. We talked about their differences, but the key thing is that when you look at flexor digitorum brevis, that's associated with claw foot. So then attach it to the middle phalanx of the toes. When you look at flexor digitorum longus, that attaches to the distal phalanx of the toes, and that's associated with hammer toe. Most of the time when you see claw foot, it's going to involve digits 2 through 5, all four of them. Hammer toe most often only occurs in one. It can occur in all, but one. These are just kind of clinical pearls of it. So if you look at flexor digitorum brevis, it overpowers the other muscles. Right? In other words, how are you getting claw foot? How are you getting hammer toe? High heels. That's one of the ways. Anything, poor footwear, anything that puts, you think about your foot being in a shoe, and if you push them together or your toes are scrunched up, to maintain that position, you have tendons that are contracting, and then they're just not going to release. So you have an overpowering of flexor tendons versus your extensor tendons. So you're shortening those flexor tensions essentially over time, especially if you're wearing high heels a lot. And so that's, in this case, brevis will pull the middle phalanx down. I'll show you a picture on the next slide. And in flexor digitorum longus, you're going to have the tip of the toe bent, while the middle of the toe is kind of cocked up. Here's the picture. So here's claw foot. What you're going to see that you need in claw foot is you're going to have an increase in the arch. And then you're going to have the toes that are pointed kind of, they look kind of clawy. Right? You can see it over here. It's cocked up and down, and if their foot was off the ground, you would see the arch is increased. There's another claw foot where, so you're looking at the metatarsal phalangeal joints are going to be hyperextended, and the distal interphalangeal joints are going to be bent. That's what makes it look like a claw. Not only footwear can cause this, neurological problems with the lower extremities, or like diabetes, which causes neurological problems of the lower foot. They can all run together. And then your hammer toe. So hammer toe is a problem with the proximal interphalangeal joint. And so in this case, the base of the toe is going to point upward, and then this is kind of just fully extended. So it's kind of cocked up. They call it hammer toe. I know they look very similar. And so when you go back and you're studying these, just look at the difference, like which one's caused by which muscle is involved in causing this. All right, so there's hammer toe. Like I said, it can involve, generally hammer toe is one toe, but it can involve them all. And actually both claw foot and hammer toe, if you start to splint them early, you can keep this from occurring, right? But if you don't, they're just gonna, and they're probably not going to come in by then, they're going to develop one of these conditions. We didn't talk about trauma causing these. Could happen. But hammer toe, once again, you're going to have bad shoes, especially high heels. You know, high heels, keep saying they're terrible for your feet. And then I think the last one, no, not the last one, club foot. You see club foot in newborns sometimes due to interuterine compression. And a lot of famous, I used to put some athletes in here, I took them out for the sake of time, is there are a lot of famous athletes that had club foot when they were born. And so club foot is defined as you have the foot is twisted inferiorly, medially, and the angle of the arch is increased. That's your clinical pearl for club foot. When you see those three, foot's twisted inferiorly, medially, and the arch increased, that's club foot, where it gives the appearance, and actually they are, someone's walking on the lateral sides of their feet. Right? And so they're walking around. And I've actually seen kids in other countries that are, and they don't get treated. This is very easy to treat in the U.S. and we do it. They do what's Consati method, which is basically progressive casting or splinting. So if the feet are rolled in, they're going to progress them back to how they should be while they're very young, and maybe corrective shoes with it if they're up and walking. And so they'll just, we won't see that. You're probably not going to see a kid in the U.S. unless it's a newborn that has club foot that will be treated. But that's the cool part of the point is you see all these things that you never would see. If you go your whole career and manage to skate by without deploying into some type of third world country, that's a negative for you. Find you one and volunteer. I mean, as a PA, there's nothing better than getting to deploy and see all these things that you wouldn't see back here. Yeah, it sucks being gone from the family, but it's a great time for medically. You never see anybody with leishmaniasis until you deploy. Somebody walks up in the U.S. with leishmaniasis, we got a problem. Okay. But in Afghanistan, leishmaniasis is like you got bit by a mosquito. It's not mosquito borne. I'm saying they treat it like I remember unwrapping this guy's arm. Because then he come into work, we had to screen him as they're coming in, and he had this thing on his arm, cover him. Like, what's wrong? And I mean, he was cratered out. Now we're not going to let him come and work on there. He's coming to work like that. I mean, I can see everything. I'm like, get away from me, man. Nothing we do for them, but we don't treat locals for that. If you're a U.S. soldier, airman, I got to include everybody. If you're a U.S. military, you get leishmaniasis. If you wanted to leave, that's the way to leave. You'll be in Germany pretty darn quick. Other than that, I ain't sending you that. All right, sorry. Plantar fasciitis. We already talked about this. Pain on the plantar surface of the heel and the medial aspect of the foot, but this is a hind foot problem. It's going to be more severe after sitting for a long time or when you first wake up in the morning. So stretch that out. You may develop a calcaneal spur, which now we're going to get into the real painful side of things. You got people going, what do people do when they develop a calcaneal spur? They don't go to the doctor, they go to Walmart, and they buy a little donut-looking pad, and they stick it on there. And just let their plantar fasciitis and heel spur progress, because they're still not doing anything to help it. But if you have that problem, the only time I see a real use for those donut pads is like if you were jumping off of something and you came down and bruised your calcaneus, those help. Eventually you'll develop a bursa that'll get all nice, hot, warm, tender. Truly the last condition, metatarsal fractures. Most time you see a metatarsal fracture is somebody had a really good ankle sprain and fractured the fifth metatarsal, or they dropped something heavy on their foot, or a car rolled over their foot. But the most common way to get a metatarsal fracture and stress fractures, if you look at a lot of the dancers, they will develop stress fractures, stress cracks, as ballet dancers. They're up on their toes. Like, I always worried about that. My daughters were doing point, they're standing up on their toes, their ankles completely unstable, but you're putting all that weight onto the forefoot, specifically your metatarsal heads, and you start to move around like that, you're going to develop stress fractures. They can become full fractures. Same thing with like shin splints. If you don't treat shin splints, they could progress to becoming a fracture. Cutaneous innervation of the foot. I'm just going until we finish here, y'all. We don't have any left. Going back to the foot, this is how I said to study. Then we have our diagram once again. Here's your calcaneus, so there's your calcaneal branches. You have your medial, and remember we had medial and lateral plantar nerve. And where we find them, here's the lateral plantar nerve, medial plantar nerve. And then you have to throw in there that we have saphenous nerve here in blue. This is your saphenous nerve. And over here in red, that's part of the sural nerve. So that's the way to look at them and the way I want you to visualize, picture them for the exam stuff. And then I told you, we're not getting into the arteriosclerosis just like we did in the hand, so go back. I'm going to run through it real quick and say, well, remember we had the external iliac and the internal iliac. Internal iliac linked to the pelvis and the gluteal muscles, and a branch went to the femoral head, the obturator branch, but we called it, right? Came out that area. Then you have the external iliac, which at the inguinal ligament becomes the femoral artery. Femoral artery goes anteriorly down the leg through the femoral triangle. It goes into that subsartorial canal, adductor canal. Then it goes to the adductor hiatus. Once it goes to the adductor hiatus, the femoral artery becomes it divides again. It becomes the popliteal artery. Goes behind the knee. Then when it goes past popliteus, it divides again and becomes anterior and posterior tibial arteries. The anterior tibial artery goes down the front of the leg, and it will enter the ankle and become the dorsal pedis artery. That's where we can check the pulse point. Posteriorly, the posterior tibial artery will come down to the foot and it will divide into lateral and medial plantar arteries. After that, we just have arches and digital branches. You don't need to go into any more arteries down there. And that means the only thing we have left is the lab. So that's awesome for y'all. I kid a lot. I don't really mind starting over. It's just the first couple of weeks. I mean, it's like a graveyard in here. Y'all were that way too. Nobody knows each other. Y'all still don't know each other. It's too big a class, right? Y'all can tell the truth. There's somebody in here right now that goes, yeah, I walked into class yesterday and saw somebody and went, you did this class? Well, picture how many classes I've done. Y'all start. When you walk up to me in the hallway outside of this class over the next few semesters, I probably won't remember what class you're currently in. I never do. I'll fake it, but this is the way I do it. So, it's a lot of students here. Anyway, so we have the lab tomorrow. We'll do it the same way. I think it's at 8, right? It's at 8, not 10. So I'll probably set it up today, and then we'll do that tomorrow. And then I will not be here for your exam. I'll be available all the way up into the exam, but then next week I have someone covering that exam. I will be available for questions after if there's an issue with a question. I will be the one reviewing it and making those changes if need be. I just won't be here physically for the exam. But y'all know how to get a hold of me, right? So, all right. Either way, you are going to do great. I think Paul's probably just going to proctor it. Somebody will be here. I won't. So, having said that, I won't talk to you at the lab. This will be my day to say, well, I know I kid a lot, I joke a lot, I'm sarcastic a lot, it's not always funny, but I am very serious when I say y'all are a great class. I have never in the history of IPAP teaching brought somebody damn cookies. and I thought about that walking in, and I'm like, those things were heavy. I'm like, well, I was asking, why are you making them so big? But I wanted to take credit for cooking them, but I knew y'all wouldn't believe me. But I really want to do that because seriously, I'm not joking when I say I've actually told the last couple of classes, y'all are a great class, but I think y'all beat them all. And y'all don't see it, what I get to see from being up here and out the hallways and talking to you individually. I've never had a class where I couldn't identify the person who didn't like me. I can always identify that person. In this class, I haven't been able to do that. Yeah, it's vain. And I think y'all realize that too at the beginning, that I said, well, we're not here to have barbecues together. We have a job to do, and I'm supposed to show you what you need to know. And so I hear these things all the time about, well, you remember my slides in the beginning? I say a lot of stuff like, this is a challenging course. And everybody always says, yeah, in the beginning you get real worried. Towards the end, you're not so worried. I know you still got one exam, but some of y'all have already calculated that you don't even need to take it. Don't do that. Don't do that. Study for it like it's the one that's going to get you. You don't want that to come back on you later. And plus, you need to know this info for later, so study. But I said, well, it's a challenging course. And I once told the students in a class, I said something about it needs to be challenging. I need it challenging. And they took that as, oh, well, Mr. Wright views it as like us against him. He needs to be the badge keeper type of person. And that's not it at all. I do not want y'all to get 5 years from now, you're out there practicing, you're being this great PA, and when you look back and somebody says, who did you have for anatomy? I don't want them to be able to look back and you go, oh, Mr. Wright was a great guy. Matter of fact, his class was a cakewalk. That's the worst thing I would ever hear. And you want to know what? Not that you can say I'm a good guy. I'm talking about that it's a cakewalk. Because we need to manage expectations. And hopefully all the way through, while it was challenging, I hope that I set the expectation where you need to be, whether you got the grades you wanted or not. Because at the end of the day, 5 years from now, and actually much sooner than that, in about 2 weeks from now, you're going to start to realize that, hey, all this anatomy stuff, you got to freaking know it. So I do, what I told them, this is what I said, I do you no favors by making this course just an easy A. No favors, man. I might as well not even be here. Hopefully y'all are taking that the right way. Other than that, treat every test like it's the one that's going to get you. What you don't realize yet, you've heard it from other people maybe, there are exams coming up that you may have one exam here and then later you have another exam, and you've got to be careful and pay attention to what's linked. Like, I don't know what's linked anymore, I haven't been paying attention. Like geriatrics and like ethics or something might be linked, where you only have 2 tests in that whole block. And you blow one of those, like you blow off ethics. Then nothing worse than going to the board because you failed ethics. So, come on now, that should be easy. I hope we get the point. Don't blow off any exam until you get out of here. Phase 2 is a blast. But just keep to the nose to the grindstone and don't let up, except for next week. Is it next week y'all are off? We got it. I'm off next week. During the break, don't study. I don't care. Keep recording it. Go tell Commander Boss of this. Don't study. It's the time for, and I know I'm taking all y'all's time, and I know y'all want to go. That week, to me, after going through this program, and I studied, I was to the wall the whole time I was here. That week, I always say, go find who's helping you get through this program. I've said this to you before, but you need to do something for the people, your family, your friends, your significant other, your buddy, whatever y'all call them nowadays. You know, I call it my wife, whatever you call them. Because what you don't realize a lot of times, you're so stressed that you fail to realize, and you think you do, but you don't. You don't realize how stressed you are even to them, and you're being a little rude, you're being short, and that leads to things like all of a sudden you're acting like you don't care about these people. You haven't walked by. You know, people think, well, I gotta appreciate my spouse. I gotta go buy her a big gift and flowers. No, all you gotta do is go home and say thank you, right? thank you. The more you say that, even if you don't mean it, say it. Because those people are struggling with you. You just don't realize it. Some of y'all do, because they're yelling at you every day, right? Some of y'all are like me, like my counselor was talking about, not my wife. My wife was great when I was here, but some of y'all spouses, significant others are going, what's so hard about it? Why? You don't seem stressed. Why you gotta go study all the time? Why you gotta leave the house? Why aren't you with the kids? And you're not hearing it because what's important to you right now? The next task. And so you start to ignore things. I'm telling you all this because you think you see it, but you don't. So go thank them during that week. Take a break off and relax. Go to Port A or go home. Y'all got leave set for this week? Don't forget about those people, because if not, guess what you're going to be? Separated, ditched, or divorced. For no reason. Because you put that goal up there to be a PA, and you need to be all into being that PA right now, and you get it, but they don't. So just find a way to say thank you. That's my last parting thought for y'all. Is because I don't want to see people get divorced or lose family or kids gone. I know I'm sounding negative, but that happens a lot here. And I really think it's because people get so absorbed in what they're doing, rightfully, that they forget just to say, hey, I appreciate that you want to study. Right? That's it. I'll see you tomorrow. We'll talk more. Make sure you grab a cookie. Even if you don't like them, tell me you do so I can tell her that they were. I'm going to tell her y'all raved on them either way.